we talk about lookalikes in spinal disorders. Very often, either in chest or in skull or in, say, urinary tract, you find almost disorders simulating each other, particularly if you take only radiographs. Then you have to correlate with clinical symptoms and laboratory symptoms. Let us see in the axial skeleton what are the lookalikes, various disorders that look alike radiograph. For example, there are two girls. Do they look alike? Yes. If you look grossly, they look alike, but there are subtle changes in the glasses. Similarly, in radiographs also, you have to find the subtle changes so that you can diagnose properly. Now, coming to the spine is, of course, backbone. Cervical, 7 vertebrae are there. Dorsal, 12 vertebrae are there. Lumbar, 5. Sacral, 5. Coccygeal varies, but generally 4 vertebral segments. Axial skeleton, why is it so important? Because the contents, namely the spinal cord and the nerves, are there, but still to protect them, there is a coverage, like the skull, which protects the brain. And then it also has got marked hemopoietic function, axial skeleton. And then the skeleton, particularly the spine, is the usual site for metastases or myeloma. What are the various imaging methods? Like any other part, you have got conventional radiographs, CT, computerized axial tomography, radionuclide scan, magnetic resonance imaging, angio. Occasionally, if there is a hemangioma or a vascular tumor, you would like to do an angio. And latest technology is positron emission tomography, with combination of multi-detector CT. Ultrasonography rarely helps except for the soft tissue component. We have to know whether it's an abscess or solid. Limitation of conventional radiology of the spine is much. That's why often we resort to CT or MRI. And now there are 3 cervical spines, 3 different patients, and which is rheumatoid arthritis, which is myositis ossificans or fibrocalcificans progressiva, and which is ankylosing spondylitis. Because if you take the one on your left side, there is facet joint fusion, particularly C2, C3, C4. Lower down, you can see the facet joint, but you see the erosions. And that indicates it must be rheumatoid arthritis. Erosions, but limited obliteration of the facet joint. Particularly in juvenile rheumatoid arthritis, it occurs. It often simulates ankylosing spondylitis. And the next one, if you see carefully, there is osteoporosis and there is a thin posterior longitudinal ligament calcification. Look at the posterior part of the C1, C2, C3, C4, C5. A thin line is bit C. That is typical of ankylosing spondylitis. And then the one on your right side, extreme right, not only facet joints are obliterated, not only the vertebral rods are small because of the limited growth, soft tissue ossifications are seen posteriorly. That is definitely myositis ossificans progressiva, or the latest term they call it fibrositis calcificans. See the subtle differences between all the 3 entities. Here again, there are 2 lateral views of the cervical spine, because we begin with cervical spine, go to the sacrum later on. One on your left side, there is narrowing of the joint space between C2, C3. Evernation is there. Facet joints are also narrowed with evernation. And there is subluxation between 1, 2, 3, 4, and 5. Look at the malalignment or misalignment, subluxation. And anteriorly, there are osteophytes. This is typical of degenerative spondylosis deformans, we call it, or spondylitis deformans. Whereas on your right side, there is no narrowing of the joint space. The cartilages are perfectly well maintained. But there is flowing hyperostosis, ossification of the anterior longitudinal ligament. And this is typical of disseminated idiopathic skeletal hyperostosis, otherwise called dish. If it is confined only to the cervical spine, you may call it focal or fish. Again, two lateral views of the cervical spine. The one on your left side, there is almost complete destruction of the body of C3, C2 and C3 with marked soft tissue swelling in a child. This is due to, of course, tuberculosis, abscess tuberculosis of the spine. The one on your right side, there is only destruction of the vertebral body of C2 and then minimal soft tissue swelling is proved to be chordoma. The intervertebral spaces are normal. Again, another example of chordoma, one on your left side. Look at the thinness or compression of C5 with anterior erosion and soft tissue swelling here also. This proved to be chordoma, although clinically they thought it may be tuberculosis, but it proved to be chordoma. One on your right side, complete destruction of C3. Anterior portion is destroyed. Not much of soft tissue swelling. Proved to be plasmacytoma. Look at the similarities. You see, after all, in bones, you can see osteolysis, osteosclerosis, a combination of these with a soft tissue swelling. These are the four parameters in the spine also. One, on the left side, C3, marked osteoporosis with the destruction of the body. The intervertebral spaces are relatively normal, although there is a cervical spondylosis in the lower cervical area. This proved to be neurolemmal sarcoma, the rare entity, but only biopsy can tell us. Radiographically, you can't tell. All you can say is destruction and then go on describing the differential diagnosis, chordoma, if it is older patient, a plasmacytoma, metastases like that. And then again, another case of TB cervical spine on the right side, because there is a lot of debate. Is it tuberculosis or something else? That's why they took a core biopsy and proved to be tuberculosis. There was not much of soft tissue swelling. Density of the vertebrae. Look at the spine on your left side. Uniform density of the bones. Could be marble bone disease, but since we know the patient has renal disease, is renal osteodystrophy. Osteosclerosis is part of the renal osteodystrophy syndrome. And one on your right side, density of the bones, calcification of the ligaments, irregularity of the spinous process, interspinous ligaments, classical of fluorosis. It's not ankylosing spondylitis. There is no calcification of the anterior longitudinal ligament. Although sometimes you can get calcification or ossification of part of the posterior longitudinal ligament in fluorosis as well as in dish. Congenital abnormality like spondyloepiphyseal dysplasia, the vertebrae are flattened, and because the epiphyses or apophyses did not grow, because they are dysplastic, the facet joints are narrowed and sclerosed. And then, of course, you have to see the entire spine in order to diagnose this and also include the hips and peripheral joints. And the one on your right side, the usual garden variety of case of spondylosis deformans that you see in older people, namely joint space narrowing, particularly C4, C5, C6 areas, and then osteophyte formation without any osteoporosis or osteosclerosis, nor any calcification of the longitudinal ligaments. Another example of chordoma, C3 is completely destroyed, soft tissue swelling is there in a 40-year-old male, proved to be chordoma. Another example of plasmacytoma, C3, I think we have seen this earlier, complete destruction, a flat vertebra plana. In older age, vertebra plana may be due to plasmacytoma or even metastases, solitary metastases, or occasionally in infection also you may get a flat vertebra. If it is child or adolescent, you think of eosinophil granule. And then talking about the posterior longitudinal ligament. You look at the one on your left side, thick calcification or ossification of the posterior longitudinal ligament in the cervical area. This is just what they call OPLL. It is supposed to be common in Japanese. Earlier we used to call it Japanese cervical disease, but today we see not so often, but occasionally in Indian population also. produces some neurological symptoms. Whereas that should be differentiated from ankylosing spondylitis. As I said earlier, in ankylosing spondylitis also you may get a calcification of the posterior longitudinal ligament, but never so thick. And then look at the anterior longitudinal ligament calcification, smooth calcification. Ankylosing spondylitis. Two different cases. One on your left side, see the ballooning and destruction of the spinous process of C2. Similarly, there is ballooning and destruction with marked thinning of the cortex of the spinous process of C2 on your right side. Almost similar, except in gradation, one is bigger. The one on your left side proved to be osteoblastoma, and one on your right side proved to be aneurysmal bone cyst. At times, both may coexist. But the ballooning, marked ballooning and thinning of the cortex can occur in an aneurysmal bone cyst, and also rarely in giant cell tumor. Whereas osteoblastoma is not that common. And if you look at the matrix, there may be some ossification, residual ossification, osteoblastoma in the film on your left side. In these two, one is straightening of the cervical spine on your left side with complete collapse of C5, and relative preservation of the intervertebral spaces. That proved to be in an adolescent, 22 years old, maybe an young adult, proved to be eosinophilic granule. One on your right side, there is congenital blockage between 5 and 6, marked thinning of the cartilaginous space, and also fusion of part of the spinous process. This congenital block vertebrae or incomplete segmentation of the vertebral column. Occasionally, you may think of a tuberculosis. Fusion of the healed tuberculosis, you may find complete fusion, but there the height is small. Flat type of vertebrae, not really flat. One on the left side, there is flattening, and anterior beaking is there. This is a cretin, 10 years old cretin. We know from clinical and other radiological data that the child is a cretin. One on your right side, there are gouge out defects and anterior beaking of one of the mid-thoracic vertebrae. This you see in so-called juvenile kyphosis or Scheuermann's disease. Those defects are due to anterior herniation of the disc due to deficiency in the growth of the apophysis. Scheuermann's. Usually it occurs in youngsters, adolescents who are sports people. And then one on your left side, marked osteoporosis with multiple compression of vertebral bodies. Similar thing is seen on your right side also, but that 12-year-old child has got leukemia with leukemic deposits in the thoracolumbar spine and marked multiple compression vertebrae. The one here also is an adult, but here look at the comparison between the left and right. Here there is what is called a fish type of vertebra, biconcave type. Because of the weakness of the vertebral body, there is herniation or a bulge of the disc material. That's why you get that depression, central depression. So look at the picture on your left side. There is slight scoliosis, and if you look at the pedicles, there is sclerosis of the left vertebra, third vertebra. Sclerosis of the left side pedicle. Okay, you have to look carefully because it's a subtle observation. Patient comes with pain and there is mild scoliosis, and you look carefully. Of course, you by CT or radionuclide scan can pinpoint, but on plain films alone, also you can suspect. Similarly, one on the right side, there is marked sclerosis of the left pedicle of L4, but then there are other degenerative changes. But that L4 is metastasis, whereas on the left side is osteoidosis. And again, going back to osteoporosis, senile osteoporosis, postmenopausal osteoporosis, you can see on your left side, whereas on your right side, hyperparathyroidism. Here also you may get a fish mouth of a vertebrae. But look at the changes in the sacrum, sacroiliac joint, subperiosteal bone, hyperparathy. So osteoporosis could be several causes, at least 12 or 15 causes, and then you have to differentiate from the entire picture. That is senile or postmenopausal osteoporosis, or early multiple myeloma, or Cushing's disease, or leukemia, or hyperparathyroidism. And the one on your left side, there is marked narrowing of the space. In the first look, it looks as if it's just a degenerative disc disease. But look at the calcified aorta, which is displaced anteriorly. That means there is soft tissue swelling. That means it must be tuberculous abscess. Maybe another infective, but common is tuberculous abscess. In tuberculous abscess, you not only get the narrowing of the disc space, but early on you can get erosions. But if it is chronic, you may get sclerosis also even. One on your right side proved to be marked sclerosis, and again narrowing of the joint space with erosions. It also simulates tuberculosis, but sclerosis is more common in brucellosis. So if there is pronounced sclerosis, although 20-25% of the tuberculous spondylitis also you may get sclerosis, but often if there is pronounced sclerosis, think of an unusual organism like brucellosis, E. coli, even fungal infection. Now, the so-called ivory vertebrae, look at L1, completely dense. But if you look carefully, the right pedicle of L3 is also sclerotic. That proves it must be a systemic disorder. It proved to be metastasis. Sclerotic metastasis, often in a male it is a prostate, in a female it is the breast, or any malignancy of the gastrointestinal tract or genitourinary tract also can produce sclerotic mets. Carcinoid, particularly a GED, is notorious for producing sclerotic mets. And then one on your right side, there is compression of the vertebrae, there is sclerosis, but there is some new bone formation on either side. The disc space are relatively normal. This proved to be tuberculosis of the spine. Tuberculosis of the spine has got morphologically 3 varieties, particularly the spine. One, it starts in the disc and erodes, particularly the anterior, inferior, or superior margins, and then resulting in narrowing. That is the disc form. Then the second one is the prevertebral ligament, the anterior vertebral ligament, subligamentous focus, and then you get gouged out defect of the vertebral body, as though there is an aneurysm of the aorta gouging out, anterior erosion. That is the pre or subligamentous focus. And then the third one is central focus, such as this, where the nutrient artery passes through, and then they deposited in the central area of the vertebral body and may produce destruction and least likely sclerosis. This is one of those tuberculosis. And then if you look carefully, the vertebra, say L4 vertebra has got vertical trabeculations, jail bar appearance they call it, or textbooks describe as corduroy appearance. This is typical of a hemangioma. What else can produce this? Well, senile osteoporosis, where the secondary trabeculae are resolved, where the primary trabeculae of the vertebra try to reinforce and reorient. You may get a similar picture. But this is classical. And then another in the thoracic spine, angio proved that is a hemangioma, not only of the vertebra, but it is extending to the soft tissues also. Another AP view, hemangioma of the vertebra. Look at the vertical bars. And one on your right side, there are also osteoporosis. Because of the osteoporosis, you may find some vertical striations, but there is compression and destruction of the right pedicle. That indicates metastasis. Metastases early on involve the pedicle because it has got rich plexus of vessels around the pedicle. Whereas in multiple myeloma, the marrow is little. So first it involves where there is plenty of bone marrow, namely the vertebral body, and then ultimately it may involve the pedicle. That's how, in general, we differentiate between metastases and myeloma. Classical case of degenerative disease of the spine or intervertebral chondrosis, whereas on your right side, there is sclerosis and extensive osteophytosis with calcification, almost simulating disseminated idiopathic skeletal hyperostosis. But here, the joint space is also narrowed. You remember early on we said that when there is a dish, the intervertebral spaces are relatively preserved. This is proved to be Charcot's joint. The patient is a diabetic. And again, compression of the vertebral body, L3, L2 on the right side, one L2 on the left side, and L1 and L3 on the right side. The one on the left is plasmacytoma, compression, with relative preservation of the pedicles. One on the right side, the pedicles are destroyed. That's why we think of metastasis, and proved to be metastasis from carcinoma of the lung. Paget disease, although rare in India, but we encounter once in a while, almost one or two every month. And then how do you differentiate from other type of ivory vertebrae? For example, look at the body of L3 on your left side. It is dense. The pedicles are intact. But if you look at carefully, it's not only dense, the width is also increased. That is, the vertebra size is bigger. So whenever a bone size is bigger and is dense, when the process extends all the way to the articular margin, think of pages. And the one on your right side is a child, 8 years old. He was playing holy with somebody kicked him, and then he came with pain, and this is the AP of his spine. Dense vertebra of L1. What is the cause of dense vertebra in a child like this? Common cause is use. Occasionally you may find sclerosing hemangioma or lymphoma. Here there is scoliosis of the spine on your left side, levoscoliosis, and a soft tissue swelling, rounded soft tissue, almost simulating a neurofibromata. But in neurofibroma, you get acute scoliosis of the spine, whereas here it is smooth scoliosis. And this proved to be hydrated cyst, and the intervertebral spaces are relatively well preserved, and there is no erosion of the ribs. Whereas one on your right side, compression, bilateral paravertebral soft tissue swelling in a 20-year-old male, and they thought of tuberculosis and radiographic findings. And then it put